tags. Okay, so our next speaker will be Brian Schwartz. He is professor in the Division of Occupational and Environmental Health at Johns Hopkins. And he's going to be talking about doing environmental epidemiological research with electronic health records.
Morning, everyone. I'd like to thank the organizers for inviting me, and I look forward to grappling with what really is an interesting set of challenges and ideas today. Steve made a lot of claims for my presentation. I hope I live up to his great adulation of what he thinks I might be talking about. I'm going to talk more about nuts and bolts of how we've been doing work to get environmental epidemiologic research done using electronic health records at the Geisinger Health System. So I'll give you a few initial thoughts about my feelings about the future of environmental epidemiology. I'm going to tell you the kinds of data that are available from health systems in electronic form. I'm going to tell you about the Geisinger Health System, the Environmental Health Institute there, and the HMO Research Network, all things that you should know about if you want to consider this as a data stream for work. And then I'm going to go into some of our ongoing research. I'll give you some examples of how we use patient data, what you can learn from patient data in digital form, how we link it to other secondary data sources to do environmental characterization. I'll give you a bit more detail about our study on methicillin-resistant Staph aureus in relation to animal feeding operations in the state, and also type 2 diabetes in relation to abandoned coal mines in the state. And then hopefully I'll have some time for questions. So just to consider a bit about the future of environmental epidemiology, increasingly, and I think we heard this from Steve, knowledge was in silos for a very long time. And when we first started epidemiology, we had our genetic epidemiologists, our environmental epidemiologists, our behavioral epidemiologists, but more and more we have to consider complex causal pathways, and we have to consider all the complexity in disease causation. And there's a lot of challenges to doing that. But in general, if you want to do that, you need a large sample size. When I first started my research career at Johns Hopkins 20 years ago, typically an NIH-funded study was about 1,000 people for 3 or 4 years of follow-up. And that's not going to be good enough to answer the kinds of questions that we want to answer. And so to do this, we're also going to require complex data streams, longitudinal, multi-level, highly multidimensional. We're going to need a lot of computational capabilities. We want to be able to study multiple varied exposures across the lifespan. We want to be able to study symptoms, signs, biometrics, and diseases. There's going to be a lot of methodologic constraints going forward. When I first started my career in environmental epidemiology, I did RDD, random digit dialing, to get my patients. Well, that was based on the idea that people had these phones in their houses with wires to them. Now they have cell phones. You can't recruit people for environmental studies anymore. So how do you get a population representative sample nowadays and a large sample cost effectively? We're also going to have to do this in a setting of funding constraints. I live in a very soft money place. The Johns Hopkins Bloomberg School of Public Health is the softest of the soft money places. And so I have to raise money for everything I do. And that's, as we all know, increasingly difficult. So this is motivating me to leverage existing secondary and new data sources to do research and see what we can learn from doing that. So let's talk a little bit about EHR data, electronic health record data. I think there's a lot of misunderstanding about what electronic health records are. I submitted a paper on electronic health record data, and one of the reviewers lamented, it would have been really good if you could have validated your electronic health record data against the hard copy medical records. I want to be very clear. There's no such thing as a hard copy medical record if there's an electronic health record. All the stuff that was in that hard copy is now in a computer. So the electronic health record is a longitudinal digital record of patient information generated by clinical encounters in a care delivery center setting. The American Reinvestment and Recovery Act of 2009 committed substantial funds to increasing the use of EHRs and claims data for research and practice. So we can use these data for relatively low cost to get large sample size and to get longitudinal data, and I'll tell you how longitudinal the Geisinger data are. We can do prospective studies. We can do genomic studies. Geisinger has money to consent there are patients who are coming in for clinical visits to take their leftover blood that might have been drawn for clinical purposes to bank it for their genes. And so they've consented about 30,000 people, and they have about 14,000 DNA specimens to do that. So you can also use this for surveillance. This is almost real-time data. And increasingly, it's being used for comparative effectiveness research, comparing clinical interventions in shorter time and with fewer costs and in prospective clinical trials. And some people who are doing CER, comparative effectiveness research, say that these data are so important to the future of that field that perhaps without these data, CER might stop. So those electronic health record data, I want to contrast those with claims data. Claims data are created by payers from bills generated by providers seeking payment for the services that they have rendered. Sources include a bunch of people who pay for health care. Access to these kind of data are becoming easier. You generally get data on all inpatient and outpatient services while enrolled in a health plan, but not the outcome of those services. Unlike electronic health record data, which are data limited to care received at one health system, claims data include all covered services regardless of the healthcare provider. And these data have been commonly used in pharmacoepidemiology and cost studies to date. So about 6 years ago now, a good friend of mine, Buzz Stewart, who's now head of research at the Sutter Health System in California, he had gone to Geisinger to direct their Center for Health Research, and he said, you know, Brian, you think we could use electronic health record data to do environmental epidemiology? And I said, well, it's worth thinking about. Yeah, let's give that a try. So we developed a memorandum of understanding between Geisinger and Johns Hopkins. It was signed in 2007. We began work in February of that year, and we had to overcome a lot of complexities. The lawyers at Geisinger had to talk to the lawyers at Johns Hopkins because they were sending their protected health information data to Johns Hopkins so that I could use it for research. So I had to sign these things called business associates agreements, data use agreements. Decisions had to be made about if there's a data breach, who pays to communicate to the patients about that. And so I'm an environmental epidemiologist, and so I looked at the region of the Geisinger Health System and said, are there any environmental health problems there, and what could we begin to work on as a proof of concept, and then maybe get some interesting results. So let me tell you about the Geisinger Health System and the Geisinger Clinic. The Geisinger Clinic is their health services side. Geisinger also has a health plan. So they have an insurance system and they have a healthcare system. The healthcare system has 40 community practice clinics and 4 hospitals. You don't have to have their insurance. I have. Okay. Yeah, thanks. You don't have to have their insurance to use their health system, and you can also use their health system without their insurance. So, but most importantly, they have 400,000 patients who have a Geisinger doctor as their primary care provider. And we think those patients represent the general population in the region. So this is a general population sample. The system also sees about 2 million specialty care patients, people who can come from anywhere for a consultation on obesity, diabetes, cancer, whatever they feel the expertise is at Geisinger. They've had an electronic health record since 2001. So when Buzz said, you want to do studies, and I said, I can get 10 years of data for low cost? Yeah. Let's talk a bit more about that. And they have a large varied geography. They have about 40 counties in the central and northeastern parts of the state. As I said, they can use the health system without health insurance. They've developed recent partnerships with the Guthrie and Susquehanna health systems in the region because we want to get more and more patients across a larger geography for some of our studies. And as I said before, the primary care patients represent the general population of the region, and 30% of them have the health plan for their insurance. So I can get claims data and electronic health record data on some of the patients. So this is the health system. Their flagship hospital is in Danville, which is around here. You can see there's about 4 hospitals and about 40 community practice outpatient clinics. And this primary market is 31 counties, but Geisinger is expanding, and when we geocode patients, we have patients.
Can you use this to point, or is that too difficult? Because that way the people on the webcast, we have a lot of them, can see.
Okay.
Thanks.
That's Danville right there for those of you on the internet. So this is the Geisinger Health System, and this is where we get the majority of our patients from. That's the state of Pennsylvania. Now, Geisinger is part of the HMO Research Network, and if you don't know about it, you have to know about it. It's a consortium of healthcare delivery organizations with both defined patient populations and formal recognized research capabilities. There are currently around 19 members representing 20 million patients. So I can study 400,000 general population representative samples, patients, if I want to work at Geisinger alone. But if I want other patients, there's been a lot of work that I'll talk mostly about this afternoon on getting data from more than one health plan and doing multi-site studies. The Geisinger electronic health record, like a lot of big systems, is in Epic software, a big privately held company in upper Midwest someplace, I think. They have data in there on both their primary care and their specialty patients. We have inpatient, outpatient, emergency, and telephone encounter information. We have information on socio-demographics and their health insurance. Maybe 15% of encounters are for patients on medical assistance, so we can use that as a surrogate for low income, for example. We have vital signs, doctor orders. We have the problem list kept by the physician of an ongoing list of the problems that the patient brings to care. We have laboratory tests, medications, procedures, imaging. All these results, however, could be in secondary databases, which means that you can't get it from their main warehouse. You have to go to the clinical departments and get it out of their clinical results databases, which is an added level of complexity, and some of it is, well, right now probably too difficult to get. And then ICD-9 codes accompany encounters, labs, procedures, medications, and orders, and we can talk a bit about how good ICD-9 codes are for research during the course of the day. So this is the environmental epidemiologic work that we've gotten started. Across the top, you see the environmental issues that we've been studying. We've been studying Marcellus shale development, a very, very interesting and hot topic on the intersection of energy, environmental health, environmental policy. Studies on the built environment, that is the food environment, the physical activity environment, the land use environment, the social environment in relation to a variety of outcomes. Pennsylvania, you would think, as they were going down the road for Marcellus shale development, would have learned from their experience with coal. Pennsylvania has the largest set of abandoned coal mines in the country, 5,000 abandoned coal mines, with all sorts of problems that I'll show you about a bit later. We've been studying animal feeding operations and then the social environment in relation to asthma, chronic rhinosinusitis, diabetes, MRSA, and obesity. And the checks tell you the various ones that we've been linking to which outcomes. And I'll give you a few details on these during the rest of this talk. So in general, in all of our studies, we get the patient data from the electronic health record. The electronic health record is sort of a complicated system, but I'm told by the IT folks there that the data exist in something like 17,000 different databases. So you have to think very carefully about what it is you want. But if you can do that, you get it IRB approved and you can get whatever data you want. We then geocode patients to their residential address. Then we think about how the environment might contribute to disease burden, and we define the exposure of interest either at the individual level or the contextual level. I'll talk a bit more about that later in relation to some of these studies. We then use geographic information systems to create exposure metrics. We often start with a number of geocoded databases, lines, points, and polygons, and we use GIS to create metrics, usually of some estimated exposure at the patient's house. Some that we use for contextual effects have been commonly used in the obesity and physical activity literatures, things like density, diversity, design, distance to sites, clustering of things across the landscape. We then link the exposure and patient measures, usually in space and time, And then we do the biostatistical analysis with complicated data structures, basically people with repeated measures clustered in places. So we do a person, place, and time analysis. So I told you a bit about where we get the patient data from. Let's talk a little bit about the environmental data. So this is an interesting geography. There's a lot of small towns. Lots of people live in places like this. Walkable, higher density, mixed use, the places that the Active Living Research Program at the Robert Wood Johnson Foundation has said for a long time, these are the places that are good for protecting individuals from getting obesity because they can walk a lot for their daily activities. In this geography, we also have a lot of agricultural lands being converted to subdivisions. We see this across the country, but this is actually one of the higher occurring states. And so we have a lot of places like this as well. And so we can use a lot of different data sources to characterize communities. And in those communities, we can look at the street networks, we can look at the location of food establishments, we can look at the location of physical activity establishments, and characterize the context in which people live in relation to ideas about how places influence the risk of obesity. And that's what we're doing in our obesity studies. So you can create a lot of measures: distance to grocery stores, distance to fast food restaurants, number of fast food restaurants within a certain number of miles of the school or the house, to study how place influences obesity risk. We have all the road networks in the region, and with roads you can determine a lot of stuff. You can use it as a surrogate for air pollution. We know what kinds of roads these are. We know the average speeds of the traffic on these roads and the average traffic volume. You can create a lot of metrics that are that have relevance to air pollution, but also to the land use environment: average block size, road mile density, intersection density, connectivity, walkability. All those kinds of things can come out of road data. We got commercial data from Dun & Bradstreet and Info USA, and we know where all the food retail and food service establishments are in the region, and you can create a number of different contextual measures on the food environment. And we have some funding at Johns Hopkins now as part of a systems-oriented obesity research center with NIH funding, and we're characterizing all of these environments in studying childhood BMI. Similarly, you can get the physical activity environment by looking at a number of different physical activity establishments. You can see here we've identified where the bowling centers are, where the fine arts schools are, fitness and recreation centers, golf courses, schools, playgrounds, etc., to see whether proximity or availability or density of these kinds of physical activity opportunities have anything to do with childhood BMI. Here is a map of Pennsylvania, and the green and red dots show where Marcellus shale gas wells have been drilled, and we see a lot of them in the southwest, and we see a lot of them in the Geisinger catchment area. And so this is actually a very interesting new environmental health set of challenges. And many of these communities are very, very concerned about it. Many of you may have seen Josh Fox's Gasland. That was in Dimmock, which is over here, where they had an accidental, that wasn't a usual occurrence, that was a bit of a disastrous occurrence there, but that showed you turn on your gas, you turn on your water fountain and you light it and the gas lights on fire. And then there's not a lot of people in these northern tier counties where a lot of the well drilling has occurred in Geisinger's catchment area. So Geisinger has been working with the Susquehanna Health System and the Guthrie Health System to begin creating opportunities for their data to connect and talk to one another so we can get as many kinds of patients up here as we can. And Geisinger has a large ongoing Marcellus Shale initiative that we've been working on. So let me give you a little bit more granularity and details on one of our studies on MRSA and animal feeding operations. This is the PhD thesis research of Joan Casey, a doctoral student at Johns Hopkins. MRSA, methicillin-resistant Staph aureus. It used to be a problem in hospitals, and the selective factor was our use of antibiotics in hospitals. But about 10 years ago or so, maybe about 20 years ago or so, we began seeing large increases in MRSA infections in persons lacking prior contact with the healthcare system. Shortly after that, new MRSA strains were recognized. These strains were rapidly disseminated among the U.S. general population, and they now affect patients with and without contact with the healthcare system. These new strains cause different clinical syndromes, particularly skin and soft tissue infections, which we see here, a child with what might be a carbuncle or an abscess, words that are important to me because I can search in the electronic health record for those conditions and do studies of them. These new strains now account for the majority of MRSA infections, and there are large reservoirs of MRSA isolates outside of healthcare facilities. So this is how we used electronic health record data to find the patients that we cared about. We actually got a full snapshot in February of 2010 of the entire electronic health record, which at that time was 450,000 primary care patients. We then looked at laboratory data and culture data and found people, about 3,000 people with a positive culture for MRSA, which is basically Staph aureus resistant to either oxacillin. Usually oxacillin is what's tested for. And then we also looked at ICD-9 codes or EP codes. Now, interestingly, in the world of ICD-9 codes, MRSA codes weren't invented until about 2007 or 2008. But Geisinger clinicians started using a system-invented code about 5 years before that. They must have seen something and asked the system to create their own code, and that's called an EP code. So we found a lot of MRSA before MRSA codes existed in the ICD-9 classification system. And the bottom line is that we combined these various methods of codes, of text searching, and of looking at cultures, and we found about, overall, about 4,000 patients with MRSA over the past 10 years. We then tried to classify them into cases that were most likely healthcare associated and most likely community-associated cases. And they're very different. The epidemiology is very different. These patients are on average about 60 with many comorbidities, and these patients, the CA patients, are on average 24 years old with no health problems. So very, very different epidemiology. And so how do we use electronic health record data to classify patients as healthcare associated or community associated? Well, we have this called our community-associated MRSA disqualification pathway. We looked at cultures within the first 3 days of hospital admission. We looked at hospitalization in the past year, dialysis in the past year, surgery in the past year, residence in a nursing home, or indwelling catheter, all things that you can use electronic health record data to figure out about the patient. And this allowed us to do this categorization of about 1,500 with healthcare associated and about 1,700 with community associated. So what we learned is that the incidence of MRSA has been going up dramatically in the region. We weren't able to do the HACA categorization over here in these years, but in years after 2005, we see that CA MRSA is now much more important than HA MRSA. The risk, these are actually rates, continue to go up, and it now represents the majority of cases. So the red is CA and the blue is HA. We're also able to use, about 20 different ICD-9 codes and CPT codes to identify people with skin and soft tissue infections. And so this is this shows the incidence of skin and soft tissue infections in the region. And clinically, that's a very important thing to look at because in the real world of clinical practice, many doctors don't need to diagnose MRSA to make it go away. They come in with an SSTI, they get empirical treatment or incision and drainage if it's an abscess, it will go away and it will never be diagnosed as MRSA. So there's other things you can use EHR data for to come up with other ways of identifying possible patients that are miscounted in other systems. What we're looking at with MRSA is in relation to animal feeding operations. And animal feeding operations, you've heard of concentrated animal feeding operations. These are basically places with lots of animals on not very much land. Traditionally, farmers took the manure that came out the back of the animal and spread it on their land. But when you have a whole load of animals in a small amount of land, you have two problems. They sort of have hygienic problems, so they put a lot of antibiotics in the animal feed. About 75% of antibiotics in this country are added for non-therapeutic purposes to animal feeds. And then they have to do something with the manure. So they put it in lagoons and they eventually apply it to crop fields in these communities. And so when you're applying manure to crop fields, you are basically disseminating antibiotics, antibiotic-resistant organisms, and antibiotic-resistant genes into communities. And this is happening a lot in Pennsylvania. So these are just the swine CAFOs. And what Joan did is I bought her a little portable scanner, and she went up to about 40 different county conservation districts and got copies of all the nutrient management plans. What is the nutrient we're talking about here? This is my favorite euphemism. This is manure. A nutrient management plan is a nice way of saying, what do you do with your manure? Well, it tells you where you apply it on the land. And so she was able to figure out which crop fields are getting manure across the street from where people live. And I go up there 4 days a month, and then there are certain seasons where you drive around, and there are lovely odors present in the air. So this shows Joan's map of where the crop field application is and then where the various patients are, as well as our SSTI group and our control group. And she did some analysis to look at, is there an association between that? She used the nutrient management plans to create this crop field manure application model. And so for a number of the nutrient management plans, we knew exactly, this is a copy from the plan, we knew exactly where the field was. So she was able to go over into Google Earth and exactly map out where that field was. And we know how much manure was applied there, and so we know the concentration and generally the season of application. For some of the nutrient management plans, we didn't know the exact crop field, but we did have the address of the importing field, so she made a buffer around that. And then for a number of nutrient management plans and their importing fields, we just knew the township of the application. So she used a land use land cover map to exclude all the land that could not have been applied to, and then randomly allocated the manure to the remaining pixels in the region. And so this looks at just briefly some of the results. So let's just look at the association of community-associated MRSA with 4 quartiles of our swine exposure model. This is based on the concentration of the manure applied to the crop field divided by the distance squared from the field to the residence. And we see that as the exposure goes up, the risk goes up, and the trend across those odds ratios is significant. So I'm not going to go into these results in detail. We can talk about them if you'd like to. Tell you a little bit about our work on abandoned coal mines. This is the thesis research of Ann Liu. And so many of you are probably aware of an EPA conference that occurred a couple of years ago that resulted in a series of papers that came out in the September, I believe, issue of the American Journal of Public Health. And basically, for example, in this paper by Couch, Community Stress, Psychosocial Hazards, and EPA Decision-Making in Communities Impacted by Chronic Technological Disasters, there was the question, what happens if you live in an area which has either what are called chronic technological disasters or what the authors also called chronic environmental contamination? So Pennsylvania has that problem, and abandoned coal mines, for us, were an interesting way to evaluate these sets of ideas. I think it's the first empirical evaluation of this at a contextual level. So what are the contextual effects of living in a community like that? So you see the houses over here, and you see a coal mine over there. This is an active coal mine, but there's lots of places where you have high walls, abandoned strip mines, open pits, orange, dead streams because of the stuff that's coming off the coal mines. And you see acid mine drainage, waste piles, subsidence, abandoned structures at 5,000 different sites across the state of Pennsylvania. And so we were able to use, we thought that diabetes, type 2 diabetes, was an interesting disease to look at in relation to abandoned coal mines because it's related to physical activity, it's related to community context, it's related to stress. And I'm going to talk more about the use of these kinds of data, but what's interesting about electronic health record data is if you wanted to study a diabetic, you might be able to think of various ways you could go into a community and identify diabetics. If you wanted to study pre-diabetes, you could think of maybe ways of going into a community and identifying pre-diabetes. But how about if you wanted to study people who were 2 years before their pre-diabetes. How would you identify such patients? Well, you can use electronic health record data to identify such patients, and I'll talk more about that this afternoon. Finally, we're interested in the degree to which community conditions can constrain the healthcare system. It's recognized that patients are on their own about 99% of the time. Community factors influence diet, activity, and stress. The best healthcare may have little impact on patient outcomes because the wrong behaviors are enabled, the right behaviors are constrained by community conditions. So here we see Joe, who's got all sorts of help from the health system, but if Joe lives in the wrong place, he's out of luck. Doctor, Joe, I want you to eat healthier foods. Joe, okay, Dr. Smith, but he lives in this place, and this place has no healthy food. You got to go 25 miles to get healthy food. So we're trying to do some research to evaluate the degree to which community context constrains the healthcare system on these lifestyle-related diseases. So in summary, there are some challenges to the use of EHR data. All of these studies are RB approved. All of these studies, we have to do a new data pull. The condition that you study, the patient must seek care. So in general, electronic health record data are probably not that good for mental health issues because many patients with depression, anxiety, et cetera, don't seek care, are not captured by the healthcare system. You cannot exactly determine if the patient is under observation and is well or has left care. Persons can enter and exit the cohort at any time. As a secondary data source, the data are not perfect, and ICD-9 coding has its problems. Some of the data we have to use are in text fields, and sometimes if you really want to look at the history of present illness, which is a big text field, you have to use natural language processing to do that. We're just getting started on that. Many variables that you might want for your analysis are not available. Certain test results, measures of socioeconomic status, there are ways we can get at those, but there's no direct measurement in the electronic health record. You can't link patients. You can't even link mothers to their children after the first week of birth. They are kept linked in the electronic health record the first week, but after that, that link is split forever. So we've been exploring a number of ways to link parents and children to look at some of the things that I think you asked about, lifespan issues, Barker hypothesis kinds of issues, by geocoding, by address, by insurance information. None of these are perfect methods. There's no measures of environmental exposures in the electronic health record, so you see what we can do. There's a large learning curve for use. There's much processing in the use of these data to get them into a usable form. I'll talk more about this afternoon. In our studies up there, though, you don't have to just use electronic health record data for their data themselves. You can use electronic health record to identify eligible patients, call them up, go see them, and collect new data. So we do a lot of studies that way as well, but those get you down to those traditional studies, 500 to 1,000 people. Our diabetes study was 28,000 people. Our childhood obesity study is 175,000 children. Our asthma studies are 25,000 people, and it's not expensive to have 10 years of data on all those patients. So it's a new world of environmental epi with these kinds of data. Thanks.